Kimberly Deppie here, presenting to you a program to provide treatment for childhood overweight and obesity. The incidence of childhood overweight and obesity is climbing in the United States. We now know that we have about 12 million obese children in the United States, as well as 23 million overweight children in the United States. And the problem is continuing to escalate, as can be seen by this slide showing those of various age groups and the prevalence of obesity that has changed from the year 1963 to the year 2008. As this problem escalates, we get into more problems with comorbidities, and these comorbidities can involve renal insufficiency, insulin resistance, diabetes, renal failure, fatty liver, hypertension, cardiovascular disease, as well as a multitude of other problems that escalate into adulthood. It is an epidemic, and there is treatment for overweight and obesity. Part of the problem with treatment of overweight and obesity is the fact that providers of healthcare fail to identify just normal BMIs or BMI in general for the childhood population, and then fail to take into account what this BMI actually is, fail to diagnose, fail to develop a treatment plan. In the future, if this continues, these children will have a predictable decreased life expectancy, and we will have an increasing burden of cost on society for the cost of the comorbidities involved with the childhood overweight and obesity, as these children will be unable to fulfill their lifetime dreams of jobs and be productive members of society. The goal of this particular program is to develop a partnership with the local healthcare providers so that we can actually provide some intervention for the children that are identified as being overweight and obese. While this may seem as a lofty goal, it is a goal that is necessary, and we are going to begin to bite this off in small chunks, but we do have to develop the program to get started. Failure to develop the program, failure to get started, will only allow the problem of the obesity and overweight to escalate within our society. To meet the first goal, first of all, we're going to increase the number of children and youth that are screened during routine physical assessment for overweight and obesity. This means that we're just going to look at what's present in the EMR and actually pay attention to it. Most EMRs will automatically calculate BMI once we measure and weigh children, and this is just stating that we're going to take the time to pay attention to what the EMR is actually telling us. The second objective for this particular goal is that the local practices will be engaged in discussing obesity prevention and reduction with children and their parents, and the available resources will be evaluated so that we make sure that we have resources available to help with prevention of escalation of the problem within our community. The third objective is to publicize resources in the medical offices so that they'll know what is available to refer the children to. Overall, for this program, what this can be interpreted to mean is that we will engage the local practices into routinely discussing obesity prevention and reduction through educational endeavors that we have, but we will also get them to engage in making referrals to programs that can help these children, as opposed to not doing anything at all. Publicizing the resources would be that we would publicize a formal program for intervention with the children who are obese or overweight. Goal number 2 is to decrease the prevalence of childhood overweight and obesity in our own community, and this would be evidenced by decreasing the number of reported cases. The reported cases are difficult because we don't report this as we would an STI, so the reported cases would have to be gleaned from evaluation of the EMR information. Positively is that through healthcare reform, identification of BMI has become a meaningful use measure. Therefore, we should be able to obtain data as to whether or not providers are identifying BMIs through their meaningful use information, which is available to the public. Further, as meaningful use goes forward, part of the meaningful use information to be gleaned will be diagnosis of overweight and obesity, and then interventions with this. And again, this can be gleaned through meaningful use information that's kept by the federal government, and we can zero this in or hone in right on our local providers as far as quality measures of their care. Objectives for number 2, first of all, we want to increase access to and use of environments that support healthful eating, physical activity, and prevention of childhood overweight and obesity in our own community. And this would be evidenced by resources being available and inviting. Some of the resources we may have available are parks and recreational facilities, as well as our local YMCA. We want to make sure that patient satisfaction with these services denotes that they do feel that they're invited and that they can participate in these activities. Also, as we develop a program that is a formal program for intervention with overweight and obese children, we want to make sure through patient satisfaction that they feel that they've been invited and feel comfortable in coming to obtain the services that are available. The second objective is to educate the healthcare providers about nutrition, healthy weight, and their role in counseling patients with obesity and overweight, along with related chronic diseases, as evidenced by educations that are offered and attended. And part of this would also be that we would have providers evaluating their educational opportunities. Part of the educational opportunities would include doing a pre and post test, and this would help us to determine whether or not they were gaining any information or actually paying attention to what was being presented to them. Raw data can be collected with regard to the event the event attendance by various local providers, and we can track who may be and may not be attending, and perhaps provide them some directed educational events. The third is to establish a support network of accessible, family-based, and culturally relevant interdisciplinary weight management services for overweight children and youth, as evidenced by the creation of services. And one of the services to be created would be a formalized program of intervention for childhood overweight and obesity. And this is part of the program that I'm discussing today. The methods of delivery. First of all, we would do in-service education to all the providers in the area. There would be formal classes available over lunch hour because we know that they would not normally take time out of their schedules to attend 1-hour services of education, especially when they do not identify the problem as being problematic to their practices. It should be mentioned here that I have done an informal survey of local practitioners, and they are finding that they do not feel they need to identify and treat overweight and obese children because there's nothing that they can do to change the problem. Also, strengths of having a formal class available over the lunch hour would be that the time commitment would be a convenient time. Most providers do break for lunch. They would have an opportunity to interact with their peers for discussion, which may change their attitudes about overweight and obesity. The weakness would be the time commitment outside the office, as we would do this in a formal setting in the local hospital in their conference room due to space. And another weakness is the fact that providers feel that the problem is insignificant. Also, method of delivery would be online PowerPoint presentations available. These would be voice-over ones that practitioners could view at their own time. Again, we'd have pre-test, post-test for these events, but this may be stronger in that it would be easier for them to use, available for repeat reviews, so that they would have the information available if they had questions as they encountered overweight and obese children and began to identify the problem and see that there was a need. A weakness would be time commitment outside the offices. This would mean they would have to do this on their own time. And again, the providers feeling that this is an insignificant health problem does not lend them to readily review this type of information on their own. Another delivery method is the actual development of a service available to patients through healthcare provider referral and self-referral, and that would be the program that I am referring to with this PowerPoint. What would be anticipated is a partnership with a local hospital. The strengths of this would be that there would be room available for a specific service. They do have exercise facilities available to the community. They have professional expertise available through dietitian and therapy, physical therapy, occupational therapy services, and these people could be a part of the interdisciplinary team to service children who are overweight and obese with their expertise. A weakness would be understanding of ambulatory services, billing by a facility such as the hospital. Also, the view of providers is thinking this is an insignificant problem, so the referrals may not be there. And also the fact that this would not be a known service to the community residents until it was developed and advertised. A second method of delivery would be partnership with the Area Bariatric Center. A strength in this would be that they do understand the fact that this is an epidemic. There is expertise within their facility to help with programming for a local program to provide services to childhood overweight and obesity. There would be resources available there. And that the physician who is the medical director of the Bariatric Center could also serve as a collaborating physician for the program on overweight and obese children. A weakness would be the goal of the Bariatric Center is usually bariatric surgical intervention, and the fact that the Bariatric Center actually has a loose connection to the community and is not a well-known entity to our community residents. Another method of delivery is to partner with area healthcare providers. A strength with this is that there could be regular provider service education on overweight and obese children. There would be ease in identification of the BMI for the children, so we would have ease in identification of the overweight and obese children for referrals from the healthcare providers. A weakness, again, would be failure to recognize the BMI as indicating need for early intervention, and again, the belief that the problem does not exist or is insignificant. Program materials that would be necessary and are necessary are PowerPoint presentation for providers, pre and post test of basic knowledge of overweight and obesity in children, quick reference guides for providers for identification and treatment, algorithm and billing codes, and intervention modalities, and EMR templates for the providers to use in their offices if they actually plan to treat overweight and obesity in their offices, so that there is some ease in providing the interventions. This is a sample of the quick reference guide that would be available for providers to take back for their practices, so that they have an algorithm to go through when they are identifying normal and abnormal BMIs for children. Once the program is developed and up and running, the evaluation will be done through a goal-free model, which focuses on how the program affects the needs that are identified. This model does not have specific goals. It's usually used to discover information. The model is based on the assumption that the evaluation should establish the value of the program, and therefore it fits a new program development in a community very well. The format also eliminates any biases because it's a discovery of information, so we don't have any preconceived needs that we're trying to ferret out information about to support. We're actually developing more information about the need and then showing a relationship between that need and the program that's has been developed and is in use. It lends itself well to continuous quality improvement because as information is gathered, the program can be changed and the intervention can be improved for ongoing services to continually meet the needs or exceed the expectations of the community. It also focuses on client needs and not institutional needs or provider needs, in that it looks at whether or not the program is actually meeting client needs rather than is it bringing in additional revenue for providers, or is it just helping them meet their healthcare reform quality initiative needs. Evaluation tools that will be used will be tally sheets that just collect raw data, and the data collected will be with regard to where the patient referral came from, the age of the patient, the diagnosis of the patient, interventions that are done, whether or not clients are able to meet their goals, what services the clients are using, etc. There will need to be a cost analysis done because we do have to be able to pay for the program. Therefore, we'll have to look at the cost of providing the service in relationship to the reimbursement from third-party payers and determine whether or not it is provided cost effectively. This will be part of the quality evaluation, and that if the program is not cost effective through an individual approach to individual patients, it may have to be group educational sessions, for instance, as opposed to individual education sessions for patient intervention. That being said, we cannot sacrifice the need for individual attention and place it in a group setting if the outcomes of the patients are not effective or demonstrating that the care is effective in correcting the problem. Patient satisfaction is a big part of goal-free evaluation, because we do have to make sure that patients feel invited to attend the program. We do have to make sure that they are getting something out of the program that's being provided, and this is measured through patient satisfaction. Provider utilization refers to providers in the community actually referring to the program, and we can collect raw data with regard to this and actually identify individual providers and numbers of referrals, and then we know how to target our marketing for the program in the future. This is a sample of an evaluation tool. This is simply the tally sheet that would be developed. It would be developed in Excel so that we would be able to analyze the data through the Excel spreadsheet methods, and then we could develop graphs and charts for program evaluation. This is the patient satisfaction survey. I do apologize for the small print here, but this is the picture of the exact survey that would be done, and it would be an electronic survey. So patients would be able to answer the questions. It can be tallied electronically and analyzed electronically. Cost effectiveness would be a comparison of the program cost to the payments collected for services. We would have to evaluate how third-party payers are reimbursing, if they're reimbursing at cost, if they're reimbursing at a percentage, or if they have a set rate for this type of service, and how this affects our cash flow with reimbursement and revenue generated. Although we don't want this to be driven totally by does it make money for the organization, we do have to be practical in that it does have to pay for itself. Development of a per charge fee is something that is done prior to the program, and then this per charge fee is evaluated as we compare the cost per visit to what we're actually charging and collecting. And then we do make adjustments so that we are, again, a self-sufficient program. Data analysis will be qualitative for the most part, except for the cost-benefit analysis is more of a quantitative basis. But the qualitative data analysis is based on the Likert scales and surveys, pre- and post-tests, etc. From that, we develop graphs, pie charts, and bar charts for presentation of evaluation data to board members for ongoing support for the program. References that were used in development of this program are included on the following two slides. Are there any questions or comments? Anything is appreciated. Suggestions for improvement, suggestions for additional information that should be considered would be more than appreciated. I would like to leave you with a little bit of humor, and I do believe that if we can find humor in a situation, we can develop a better understanding of a situation. Attached here are just a few slides that I've found as I've done work on obesity that lend itself to helping understand the epidemic that we currently have. Thank you very much for your attention to my project.